Hi, this is Professor Brandy Stanley, and today we are going to look at assessment of the neurologic system. This is found in Chapter 24 of our current textbook, and if you will notice at the first part of the chapter, it covers the structure and function of different parts of the central and the peripheral nervous system. It's important to have a good background and knowledge about what the structure and function of the parts of the system are because you are identifying problems on assessment and you want to be able to understand why these problems may be occurring. So if you could review that, of course you've already had this content in anatomy and physiology, but you may need a quick refresher, so please read through the first part of the chapter in your book before beginning assessment of your patient. We've already talked about how our assessment consists of both subjective and objective data. The subjective data being the patient report and the objective data being our observation of signs. So let's take a look at what the beginning is, which is the history or the subjective patient report. We are going to assess a number of factors which may indicate neurological problems, such as headaches. When we find out that the patient reports a history of headaches, we are going to have a more expanded questioning, which is going to consist of things like when did the headache start? How often do they occur? Where are they located? And are they associated with anything? You know, a headache can be a result of something very benign, such as recent caffeine discontinuation or ingestion of nitrites, or it can be a sign of something more sinister, such as a head bleed. So when we're assessing headaches, we are going to be concerned especially with headaches that are the first or the worst ever. These are going to be sinister signs. Another thing that we might assess with a patient on a neurological assessment is going to be a history of head injury. We're going to find out what part of the head was hit, and was there a loss of consciousness, and if they remember details of the event. Because a concussion does come from a direct blow that causes rotation of the brain inside the skull and shear injury, and this can actually result in permanent damage to the brain that can cause neurological problems. We might assess dizziness and vertigo, which is a lightheaded feeling and a swimming sensation or feeling faint. We're going to assess seizures, whether or not there's a history of seizures, when they started, how often they occurred, if there are any warning signs such as a light, also known as an aura, whether or not there's confusion after the seizure. This is called a post-ictal phase, where the patient is confused and disoriented, whether or not there was weakness, headache, muscle aches associated with the seizure. And we might even find out what type of seizure it is. Is it one where the patient just kind of tunes out to the environment, or is it something where they have the full-blown muscle twitching and grand mal type seizures? We're going to assess the presence of tremors. And tremors are shakes in the hands or feet, and they're involuntary muscle movements. We're going to assess the presence of weakness. Any weakness or problem moving any body part is going to be a question we'll ask. Is it generalized or local? Like, is it one-sided or is it on both sides? We're going to look at problems with incoordination, numbness and tingling, difficulty swallowing, difficulty speaking, a history of illness like stroke, spinal cord injury, meningitis, encephalitis, alcohol use, congenital defects, and environmental or occupational hazards, because all of these things can cause problems with the neurological system. I would refer you to page 634 and 635 for the expanded version of questions you might ask to each one of these points when the patient identifies a problem. Please note that the information found in the textbook contains additional assessment pieces you are going to want to collect for children and for aging adults found on page 636 and 637 of the textbook.
So as we begin our objective findings, let's talk about the assessment of the cranial nerves. The first cranial nerve is the olfactory nerve, and it is not routinely tested as part of a normal routine assessment, but when we prepare to test the first cranial nerve, we will use something that is a familiar smell, such as coffee or maybe even alcohol wipe, and you will have the patient occlude one side of the nose with the fingertip, and then close their eyes and ask them, as you place the thing in front of them, to identify the smell. They should be able to identify the smell, and they should also be able to smell it on both sides. So you will test it bilaterally, and ask them if the smell is the same on both sides and whether or not they can identify what the smell is.
The second cranial nerve that we will test is the optic nerve, and that will be found in Chapter 15, so we will go over that next week. Next, we are going to be testing cranial nerves 3, 4, and 6, which are the oculomotor, trochlear, and abducens nerves. First, we are going to start by checking the pupils, and we will use a pen light to do this. What we should find is that the pupils are equal, round, reactive to light. If the pupils are uneven in size or do not react to light, then we know that there is a problem with the cranial nerve. Both the pupil reaction and the extraocular movements are going to be covered in Chapter 15 as well, and we will go over those next week. It is just important at this time that you know that they are part of the cranial nerve assessment. Next, we will be looking at the back and forth movement of the eyes, which is called nystagmus. Now, some minor degree of nystagmus is normal when you have a patient looking to the extreme outside edge of one direction or the other, but we should not see oscillation of the eyes, otherwise that is an abnormal finding. I am posting a video of my own eye because I do have some degree of this which occurs, the oscillation. It has more to do with my ability to focus related to a weakness in that eye, but I am posting it so you can see some of the oscillations that may occur when you are looking for this on assessment. Of course, a normal finding would be no movement of the eyes when doing a cover-uncover test. Another thing that we're looking for with this part of the cranial nerve assessment is what is known as ptosis, which is a drooping that can occur with conditions such as myasthenia gravis. And so a normal finding would be that both eyelids are open equally, and a drooping or ptosis might occur to indicate an abnormal finding. The fifth cranial nerve, or the trigeminal nerve, is assessed by palpating the muscles of mastication while asking the patient to clench their teeth. Muscles should feel equally strong on both sides, and then we want to try to separate the jaws by pushing down on the chin. And normally you cannot open the mouth or push down on the chin and expect to see movement. We are also going to test the fifth cranial nerve by testing sensory function using a Q-tip or a cotton ball or something soft. We're going to ask the person to close their eyes and lightly touch them and tell them to say now when they feel the sensation. They should be able to feel this equally on both sides and be able to identify when they are being touched. If there is decreased or unequal sensation, this could be a sign of a neurological condition such as a stroke. The next cranial nerve is the facial nerve, which is the seventh of the cranial nerves, and we are going to note the mobility and facial symmetry as we ask the person to do things such as smiling, frowning, closing their eyes tightly, and then trying to open their eyes while they're keeping them closed, showing their teeth, puffing their cheeks, raising their eyebrows. All of these things can indicate either a proper functioning or an improper functioning of the facial nerve. Next, as part of our cranial nerve assessment, we will assess the eighth cranial nerve, which is the acoustic, also known as the vestibular-cochlear nerve. The vestibular-cochlear nerve is tested by seeing whether or not a person is able to hear normal conversations and by doing a whisper voice test, which we will learn when we cover Chapter 16 in the book. We will test the ninth and 10th cranial nerves, the glossopharyngeal and vagus nerves, by using a small tongue depressor and asking the patient to open their mouth and say ah. We should note that the uvula and the palate should rise in the midline and the tonsillar pillars should move medially. We will then touch the posterior pharyngeal wall with a cotton applicator stick and note the presence of pharyngeal sensation, but we do want to avoid the gag reflex because we don't want to make the patient gag. Also note the vocal quality. Is it smooth? Is it not strained? So we now know our normal findings are that symmetry and that good vocal quality. But what our abnormal findings are going to be is an absence of symmetry of the soft palate movement or the tonsillar pillar movement. And this can follow a stroke and may indicate that there could be problems with swallowing and an increased risk for aspiration. This is why it's important to assess that. A hoarse or brassy voice may occur with vocal cord dysfunction, and a nasal twang can occur when there is weakness of the soft palate. We will assess our next cranial nerve, which is cranial nerve 11, the spinal accessory nerve. by examining the sternomastoid and the trapezius muscles for equality of size. We will then check the equal strength by asking the person to rotate the head forcibly against resistance applied to the side of the chin. Then we'll ask them to shrug their shoulders against resistance. These movements should feel equally strong on both sides. If there is atrophy or muscle weakness or paralysis, then you will find that there is not equal strength, and that would be an abnormal finding. This brings us to our final cranial nerve, which is number 12, the hypoglossal nerve. It is likely we will assess this nerve at the same time we do cranial nerves 9 and 10, the glossopharyngeal and vagal nerves, because we will already be in the oral cavity at that time. The hypoglossal nerve, cranial nerve 12, is assessed by inspecting the tongue. We should note no wasting or tremors present in the tongue, and then ask the patient to protrude the tongue and note the forward thrust of the tongue. Is the tongue in the midline or is it deviating to one side? Because a deviation to one side could be an abnormal finding and indicate the possibility of a previous stroke. Ask the person to articulate or to say light, tight, dynamite, and note their speech. Is it clear and is it distinct? So this concludes the portion of the cranial nerve assessment when we're talking about the neurological examination. Let's go ahead and move on and realize that a lot of the pieces of the cranial nerve assessment may be included in part in other parts of our assessments as we assess a patient's neurological functioning. While I am including these as separate categories so you understand what you're assessing, please note that when you are completing a patient assessment, you will do it in an organized manner, usually from head to toe, assessing all aspects of the patient's neurological functioning and health status. So let's proceed to the part that involves the motor system musculature. And first we are going to look at the patient and inspect the size of the muscles. We're going to note whether or not there's symmetry bilaterally, and muscle groups should be within the normal size limits for age, and they should be symmetrical. If muscles in the extremities look asymmetric, then measure each in centimeters and record the difference. A difference of 1 centimeter or less is not significant. It is also worth noting that it can be difficult to assess muscle mass in people who are very obese. Next, we are going to test the musculoskeletal strength, and while you may recognize this as belonging more with the musculoskeletal system assessment, it is also going to be a part of neurological functioning because certain neurological conditions such as stroke can cause problems with muscle strength bilaterally. So every time that you assess musculoskeletal strength, it is going to be done bilaterally. So for example, you're going to ask your patient to grip your hands bilaterally with both hands at once. You're going to ask your patient to perhaps press down on the palms of your hands with their palms, or to lift up against pressure that you're applying with your hands. You might ask the patient to lift their legs against pressure that you apply, or to push down on your hands with their legs. All of these things should be a normal symmetry of the movement as the patient presses down. If there is weakness on one side, that can be indicative of a neurological problem. The next part of our neurological assessment of the motor system is muscle tone. Tone is a normal degree of tension that is going to exist even when muscles are relaxed. And in order to test that, for example, in the arms, we might put our hand on the patient's elbow and our other hand on their wrist, and then move their arm back and forth in a range of motion. We might tell the patient to relax completely or go limp like a rag doll, and we're going to move their arm. It should be a fluid motion as we move their arm and no jerking or tension that is abnormal noted, and it should be about equal bilaterally. We can also test this in the leg and the knee. The next thing we are going to assess is involuntary movements. Normally, no involuntary movements are going to occur, but if they are present, note their location, the frequency, the rate, and the amplitude. Note that the movements can be controlled at will by the patient. So this concludes part 1 of our neurological system assessment, and I will continue in another video with part 2.